start, madam? Respected chairpersons and learned audience. I am Dr. Shakhawat Alam, Assistant Professor of Pediatric Cardiology in BSMO, going to present my case. Transthoracic echocardiography, evaluation in case selection for transcatheter VSD closure and its significance during the procedure. VSD is the most common cause of congenital heart disease in our center as well as in this subcontinent. And there are 4 types of VSD according to anatomical location: perimembranous VSD, inlet VSD, outlet VSD, and muscular VSD. Out of these things, out of this muscular VSD, and there are 3 types of muscular VSD. One is anterior, mid-muscular, and posterior muscular VSD. Out of these 4 types of VSD, only perimembranous and the muscular VSD are suitable for device closure. What we see for with the device closure with the echocardiography, we see the anatomy of the VSD, like morphology, morphological location, and size and number of the defect, and presence of valvular overriding or septal malalignment. Number 2, assessment of the chamber size, identification of the associated location, and assessment of suitability for percutaneous device closure, and to decide about the selection of the device. What we see with the Doppler echocardiography, with the color Doppler, location of the VSD, especially smaller VSD and multiple muscular VSD, size of the VSD, and the determination of the shunt direction across the ventricular septum. With the spectral Doppler, what we see is interventricular septal gradient with the help of the color flow mapping, and all small turbulent flow should be confirmed by the pulse wave and continuous wave to prevent the false interpretation of the color flows and shunt calculation. So now my case. Mr. X, 18 years young boy, hailing from Sharupkati, Borishal, 3rd issue of a non-consanguineous parent with a poor socioeconomic background, came to our hospital with the complaints of repeated history of respiratory tract infection and occasional breathing difficulties. He was first diagnosed to have congenital heart disease at 1 month of age with the registered physician locally during the routine clinical follow-up, and referred to Dhaka for further evaluation, but with the financial constraint, he was not able to come to Dhaka for more evaluation. At 6 years of age, he was first evaluated by echo and diagnosed to have congenital heart disease, VSD, and advised for surgical repair, but failed with the same financial problem and left with oral medical management. And next, at 16 years of age, he was re-evaluated by echo and advised for transcatheter device closure, and it was late because of COVID pandemicity. On examination, he was thin-built, anxious-looking. He was 5 feet 5 inches, but weighed only 55 kilo. His vitals are 100 beat. Heart rate was 100 beat per minute. BP was 130 over 80 millimeter of mercury. Chest findings were normal. His visible apex beat was on the 5th intercostal space at the mid-clavicular line with a systolic thrill, but no heave. And the first and second heart sound was audible, but second heart sound was merged with the pansystolic murmur at the left lower sternal border, and no other murmur was there. On ECG, his heartbeat is about 110, and on there is no normal PR interval, and there is LV strain is there, and mild LV left axis deviation was there, and X-ray showing cytosolitas, levocardia, and there is no much cardiomegaly, and there is no pulmonary hypertension like plethoric lung field. On echo, we have assessed the echo. There is a left to right shunt, and it was measured about 2.97 millimeter. 3.97 millimeter. And there is a left to right shunt with high interventricular gradient, meaning there is normal pulmonary pressure. কিন্তু ইয়াটা আসতেছে না কোনো স্লাইড শেয়ার কিন্তু আসতেছে না
এটাকে ক্যান্সেল করে নাকি আসছে আসে না স্টার্ট কেউ আসে না না
প্লে এখানে দেন
আসছে কিনা আসে নাই এই যে আসছে
কিন্তু ইয়ে কই পাওয়ার পয়েন্ট লিংক ডিসটেন্স কই
কোনটা স্যার
এটা তো ইয়ে আছে
কোনটা
পাওয়ার
ভিডিওটা
পাওয়ার পয়েন্ট গুলো তো আসতেছে
কি এটা ভিডিও ছিল স্যার এই আসছে তো
কিন্তু আসছে তো বড় হচ্ছে না স্ক্রিনটা
না না ওইখানে তো বড়ই আসছে আপনার স্ক্রিনে নেক্সট স্লাইডে আপনি করলেন স্লাইড তো এখানে ঠিক আছে স্যার
So we have selected this case for device closure, and this is an isolated BSD with normal pulmonary pressure, and BSD location is away from the valve, aortic valve. So we have selected this case for device closure. And the device, according to the morphology of the BSD, we select ADO2 ADO2 for BSD occlusion. And we have done an NGO in a LA cranial view. Cranial NGO showing small small BSD, and it is away from the significantly away from the valve, aortic valve. And it is significantly away from the aortic valve. And we cross the BSD with the Terimo wire, and we have placed the Terimo anchor in the pulmonary artery in an integrate approach. And we have we have this, we have assess the BSD device with the equal that both sides, the RB disc and LA disc are open. And here it is showing that both the LA disc and LV disc is there in the right position.
Sorry, your time is up.
Yeah, just 1 minute. And no, it is porita then porita. Yeah. And according to, we assess the VSD the device just after before the dislodgement, deployment, and it is showing there is no aortic regurgitation, and we have deployed this device successfully with 6x6 ADO2 VSD device. And on conclusion, transthoracic echo is very crucial in VSD selection and device selection for the transcatheter device closure, as well as during the device deployment and follow-up. Thank you very much.
Thank you, sir, for your excellent presentation.